What I'll be talking about in this video is the first tier of data entry for renal or bladder trauma. Typically, the persons responsible for this would be the trauma registrars or a designated person at your institution with ready access to the trauma registry. Much of the information is entered into the trauma registry for maintenance of the level 1 trauma certification. From this initial entry page, you'll enter the site. The study will come up, study 15. You'll go to site enrollment list. You have already entered your hospital information, and now you go to new subject. This is the introductory page for new subject entry. The first question is whether the patient has a renal trauma. So if the patient has a renal trauma, then you can proceed and say yes. If the patient does not have a renal trauma, answer no, and then the program asks whether a bladder injury occurred greater than grade 2, which just indicates there's a luminal entry into the bladder or a full thickness bladder entry. In this case, we'll enter a bladder injury patient as a sample patient. So we say yes. Then this brings up the demographic entry. Age, we'll hypothesize this patient's a 22-year-old. And then under sex, male. And then you can enter either height and weight or a BMI if it's available, either one. Height, you can enter in inches. We'll say this patient's 72 inches or 6 feet, and he weighs 205 pounds. The program will automatically enter a BMI. It's not necessary to enter the height and weight if the BMI is known. You can circumvent those steps. The date of the injury, we're going to say that this patient was injured on March 1st. And the time of the injury. This can be obtained from the paramedic record, or it can be obtained from the admitting emergency department record. An approximation is what we need here. It's not required if the time of entry is time of injury is unknown, but we highly recommend that this data be entered if it's available at all. We'll say this patient was injured at 8:15 in the evening. And the date of hospital arrival. So this isn't quite intuitive, but this would be for a transfer. So say the patient was injured up in a rural part of your state, seen at a tertiary emergency room, and then flown to the Trauma 1 facility. That's often the case at Utah, and so we'll say that the patient was seen on March 2nd at our facility, and that the patient arrived at 3 in the morning after being evaluated at the tertiary facility. Date of discharge is self-evident. How long the patient stayed, we'll say this patient stayed for 1 month. And then it'll calculate the length of stay of the patient automatically. The discharge status, was the patient alive when discharged or dead? We'll say alive in this case. The ICU length of stay, you can check unknown if it's not known, but please fill this in if this is part of your trauma registry. We'll say this patient stayed in the ICU for 5 days, and this patient was transferred from another facility. The next is the comorbidities. These are comorbidities that are designed to be readily abstracted from the trauma registry data. That's why we picked these data points. And we agree there may be other comorbidities that are very important. However, they're not easy to abstract from the record. All of these are placed into the trauma registry and are easily obtained from trauma registrars. So this patient's 22, he's totally healthy, he was just in a motor vehicle accident. You can click multiple ones of these comorbidities, all that apply. So we'll leave these blank in this patient. Next, the injury type. This patient was in a motor vehicle accident, so we'll say blunt. And then it'll bring up general categories. So this guy was in a motor vehicle crash, but say this was sports related and we wanted to put in the type, and we'll say snowboarding. Please put in some type here if the patient has sports-related injury, or these are not descriptive of the mechanism. Like, for instance, a patient crushed by a refrigerator. You could say crushed by refrigerator here. By object. Refrigerator. And that gives us a little more detail about this. In this case, we'll leave this as just a simple motor vehicle crash and keep things simple. That's going to be most patients have a simple mechanism that's captured in those areas. The injury severity score, we'll say his is 23. This is also from the trauma registry. And then the concomitant injuries. Did the patient have a pelvic fracture? Patient in this case did have a pelvic fracture. Was there any other injuries? And we'll say this patient had a splenic laceration, grade 3, and then spinal cord injury, no. The next concomitant injuries are major vascular, and in his case he did not have any of these major vascular injuries, but if he did, then you could mark all that apply. The emergency room disposition. Was the patient, did the patient die in the emergency department? Was the patient taken to the trauma ward, ICU, or immediately to the operating room? And in this patient's case, the patient was taken immediately to the operating room for exploration for free fluid in the abdomen. Laparotomy. The patient did receive a laparotomy, and it'll say the date of the first laparotomy. He was taken immediately from the operating room, so we're going to say the date was March 2nd. And he arrived in the operating room at approximately 3:45 after being assessed in the emergency department. Was the abdomen left open after the initial laparotomy as a part of damage control? This patient had bladder injuries that were identified, but no other serious abdominal injuries, and the abdomen was closed. So let's say no. The patient did not receive a thoracotomy. If he had, this would bring up the date of the thoracotomy. Angiography. Were the patients taken for angiography? We'll say that after his laparotomy, he continued to bleed, and so he was taken for angiography. And we'll say this also occurred on March 2nd. And the timing was, since he had we'll hypothesize a bladder repair, and then he was taken to angio afterwards, we'll say the time was 7:20 in the 7:20 in the morning. Was angioembolization or stenting performed? And we'll say in this case it was. So patients can go to angiography and just get a diagnostic angiography, and if they don't undergo the procedure of angioembolization or stenting, then this could be left as a no. In this case we'll say it is. And what was done? And these are all that you could apply for embolization versus stenting. So we'll say in this case a branch of the left internal artery was found to be bleeding and was embolized. Did the patient require another angiography? In this case, no. If we had answered yes, it would bring up this same loop of specifics on angiography. And this keeps getting brought up until at some point it says, was additional angiography required? And then you just fill in some descriptor. In this case, we'll say he did not require additional angiography. The AAST grading is important to check, and so we'll say in his case he had an extraperitoneal wall injury that was greater than 2 centimeters, and he also had an interperitoneal injury. And so he falls into the this category here of grade 3, and this will be something that the trauma registrars will enter in the data base that your facility maintains. And then here, this is a double check. It says injury or laceration into the bladder lumen, and here we say no, indicating that actually the patient only had a contusion to the bladder. This is a double check that we don't go on and enter this patient as a true luminal injury. So this answer should always be yes for these patients. And then specifics of the injuries. These can be left blank if the trauma registrar and the first tier of the system is not able to answer these. So in his case, he did have a bladder neck injury. There was no urethral injury, and the patient did not have a ureteral injury. The initial management of the injury in the first days, so 4 days. So in essence, a immediate injury management, given that many patients may be too unstable to have a bladder injury repaired, or bladder injury might be repaired at the time of orthopedic stabilization. We felt the first 4 days would cover the majority of the intent of immediate bladder injury given different clinical circumstances. So we're going to say this patient had immediate bladder repair, and the date of the bladder repair was March 2nd, when he was explored in the operating room for bleeding. And then the time was similar to the laparotomy, which I believe, let me go up here and see, might be a little bit later in the record, given that it was first explored by general surgery, but I think it would be at roughly the same time on the medical record. So we'll say 3:45, time of first laparotomy. This should be apparent also in the trauma registry. So we'll say 03:45. Who did the repair? General surgery, acute care surgery, or urology. We'll say this case was complex and urology was consulted because of the bladder neck injury. So we'll put in urology. And then orthopedic procedures on the pelvis is important, and we'll say that this patient underwent multiple orthopedic procedures. The first was on May 4th, after he had recovered somewhat, and we'll say posterior, and this is from the operative report. Percutaneous pins placed in left sacrum, for example. And then the patient underwent anterior fixation several days later. We'll say on the following day, the following day, after no bladder leak was apparent. We'll say anterior plating of the symphysis pubis, and that's all he underwent. These are pelvis procedures only in orthopedics, not for distal fractures, treatment of spinal fractures, etc. So then we need to upload the radiology, and this will be in a separate section of videos. And so the trauma registry or registrar's responsibility will be to send the patient's medical record number along with the AAST de-identified number to a designated person in radiology, who will then be responsible for uploading these scans. And so we can see the trauma registrar should go through and find out what scans can be uploaded. This patient had a CT of the abdomen and pelvis, a CT cystogram. He had a cystogram post-operatively to make sure that the area had healed. He also had a retrograde urethrogram to rule out urethral injury after the bladder repair. And then he also had pelvic x-rays that were done initially. And these are plain x-ray films or pelvic CT scans. So now we go on to advanced questions. And this terminates the portion of the entry by the trauma registrar. Now at this point what we envision is the trauma registrar will keep a list of the patient's medical record number, institutional tract number, and also the AAST number assigned to the patient. And then this list will be communicated with the designated person and the trauma team that will answer these advanced questions. This list will also have to be communicated with radiology for upload of the radiologic images to the AAST site. This is a labor-intensive study. However, GU injuries are quite rare, even at institutions that treat the upper level of trauma, and so this should only constitute several injuries per month, and that's why we think this should be feasible. Now the trauma registrar would come down here and would put in pending. This is very important that complete not be done until the study entry form is complete. This is of critical importance because you can't enter data very effectively once this has been completed. We would have to switch over the form through communication with the personnel at the AAST to a pending status. So we'll hit pending here. And this assigns our data entry for the patient, 15.2.1. Now, when we go back, we should have a patient labeled 15.2.1. So now when we reload the main page and go under site enrollment, we see our new subject has come up, 15.2.1. Now from this page, trauma personnel associated with the trauma team, such as a mid-level, fellow, or trauma surgeon, can go and edit the record and finish the advanced questions or unanswered questions that were throughout the record. And here are all the advanced questions down here. In addition, personnel from radiology will be able to upload scans to the site. And so here we would say CT scan from 5/1/2014, or sorry, 3/1/2014, which was the initial CT. And then we would upload a file, and this will be the subject of another video.